Hello everyone, welcome to the Zoom meeting. Today we will have the agenda as listed here. So the white team will lead this Zoom meeting. So when you are ready, Dr. Shata, thank you so much.
Hello, everybody. My name is Dr. Saba Irfan, and I'll be moderating the session today on the behalf of the white team as the team leader for subgroup A. And before we proceed, we can just go over the plan for today. We have a total of 6 presentations today. The first one being dementia. The first one, we've changed the order a bit. So the first one is we're going to have the first one by, let me just double check. I'm sorry about that. We just changed the order for the topic of presentation. So the first, I'll share my screen. Is it visible?
Not it.
Okay.
No, not yet.
Okay, I think I need to figure it out. Anyways, the first topic that we have to work, that is going to be presented by is going to be on mobile apps for older adults. It's presented by Dr. Elmoez. The second topic is on dementia. For that we have 2 presenters, Dr. Yaqot and Dr. Hadeer. And for the third topic, we've got the topic is organizational skills. That is presented by Dr. Ali Shata. And the fourth topic today is going to be how to organize your, it's a topic, it's a presentation on organizing your digital files. That's going to be presented by me. And then we have finally, the fifth presentation is on oral cancers. That's going to be presented by Dr. Walaa. And at the end, we're going to have a quick discussion of all the ongoing projects and any other upcoming plans. So if Dr. Nader, you would allow, I would like to start the session, and I would like Dr. Elmoez to start with his presentation.
Sounds good. Thank you so much.
Dr. Elmoez, you're not audible.
Dr. Elmoez, we can't hear you.
No? Now it is okay?
Yeah.
Yes.
Yes.
Okay. So I'm gonna share my screen. Let me go.
Assalamualaikum.
Salam.
Walaikum salam.
Okay, assalamu alaikum.
Walaikum salam.
Okay, today I'm presenting this topic regarding the mobile apps for adult. I'm Dr. Elmoez. I'm residing in Atlanta, Georgia. Thank you, Dr. Nader, for this opportunity, and on behalf for the white team. Let us go and through my presentation. Okay, so the topic today will be mobile apps for adult, systemic search and evaluation. Okay, for introduction, when it comes to searching and evaluating mobile apps for adult, especially in a systemic manner, here are some steps you can follow during searching. The first step, we have to define which and specify the needs and purpose of the app you are looking for. Do you want this app for productivity, for the health, or for fitness, entertainment, or education? Any section have different apps, so you have to decide which one you want to download it and for what you are gonna use it. A second step in the searching, you have to look for trusted website. And also we have to look for the review platform or app store ranking for the apps you are searching for. Third step in searching, you have to read application description and the reviews and to look for both the positive and negative reviews because both of them are very important, the negative and positive. According to this, you can decide which one, because there is many application for any topics that you can decide which one you can use it, depending on this ranking and the positive things and the negative things. Number 4, you have to check the application rating and the highest the rating and a significant number of download, this means and indicates that the app is well received by the users before you. Number 5 is we have it here. We have to evaluate the user feedback and comments. This will be found in the store. You can see the feedback and comment from the previous users using this app. Number 6, consider the app updates and support. This indicate ongoing maintenance and improvement because you know the technology is improving day by day, so you have to look for the updates every day and every moment. Number 7, we have to try the use app before making a final decision, and by following this step, you can approach your search for mobile app for adults in a systemic manner. So let us go through and to look for the type of mobile apps used for adults. There are many mobile apps that can be beneficial for older adults. Number 1, we have the mental health application. Number 2, we have the fitness and exercise application. And number 3, we have medication management application. This is very important apps for adults and elderly. Number 4, we have social network application. Number 5, we have news and information applications. Number 6, we have transportation application. Number 7, we have personal safety applications. As we can see in this slide, there's many types of health application used among adults aged from 50 to 80. This is elderly. We can find many applications regarding the exercise, nutrition, weight loss, sleep, blood pressure monitoring, and diet and nutrition. Number 1 of the type of applications that can be used in elderly, the mental health application. As we can see here, there's multiple applications that can be gonna use it, and you can find in the App Store or the Google Store. We can find can use the code below, Optimism, Big White All. They are different types of apps that can be used in mental health. For mental health, why we use this application? We use this application for mental exercise and games to help improve the memory and cognitive skills. As we see in this ranking, we can find that the medical application, they are the most downloadable application in the in the stores. There's a different store, App Store or Google Store, coming in the top of the application that are be downloaded every day, because they are different use for this medication or medical use applications. Number 2, we can discuss now the fitness and exercise application. This is very important as in young adult or in elderly also. We can use this application to provide the workout routines. This can be very important if you want to go through the workout in home and if you have no time to go to the gym. Also, you can find in this app many exercise videos. And the number 3, we can find and track the feature to help adults stay active and maintain their fitness and exercise. The most important and best fitness application in 2023, we have Fit Plan, we have the Gym Shark, we have the Get Fit, we have 7, we have also Strong, we have this Nike Training Club, we have Pair Fit, and we have my fitness.
Hello, Dr. Elmoez. We can't hear you.
I think he got disconnected, maybe.
Yeah, I think that
Okay. So, while waiting for him, should we move on to the next presentation, or Dr. Nader, do you want us to wait for her to connect, for him to connect back?
he's back.
Yeah.
Okay, he's back.
Yeah, it is okay now.
Yes.
Yeah, you good.
Yes.
Okay. So as I mentioned before, there is many application, not this only, but this is the most ranking application and most used by the most downloaded application in 2023. You can choose among all this, go to the ranking and the reviews, and after that you can choose anyone and can be use it for your fitness. Number three, transportation application. This application is very important for elderly and for young adult because these apps can provide transportation as a Lyft and Uber, and this transportation method can be in front of your house. No need to go and stay a long time waiting for the bus or something. So the most common use transportation application will have Uber and Lyft. Number four, we have the personal safety application. This application offer features such as emergency alerts, location sharing, and personal safety tool to provide peace of mind to older adults and their caregiver. And this we can see in iPhone that there's many features that is very important to the health that can be alarming the patient if there is any emergency in his condition and can call the caregiver also, and can give you also the next step what you have to do. The most common application used for personal safety apps, we have the Life 360, we have Be Safe, we have Family Locator, we have Red Panic Button, we have My Safety Pin, we have Safe 360. As I mentioned before, which one you can choose it? You can choose the most ranking one, and the most is a symbol is for you and for your family. Number five, we have the medication management apps. And as I go through my and during preparation for these slides, the most important one it is this one, because medication management application, it is not important only for the elderly and those who have dementia or any memory problem, but also even for the younger, because this will keep you tracking your dose and medication. And also there's application that can be set a reminder for taking pills also, can remember you of, if you forget your dose or something. And also it is provide information about the drug interaction and side effect. I think this is the most important application and can be and should be in any phone of any person of us as adult or elderly. This slide contains some applications that can be used to manage your medicine. We have different ones: Early Grade, Round Health. We have Bill Bag, Medication Helper, and Mango Health, and My Medication Schedule. Number six, we have the social network application. And this I know anyone knows these applications: YouTube, Twitter, and Facebook, and Instagram. This different application socially can help the adult to stay connected with friends and family, and to share the photo and the videos and to engage in online communities. So it is very important and very helpful. And the last and not the least, we have the news and information application. This application delivers the new update, the weather forecast also, that you can plan your date according to the weather. And also you can access to article or broadcast on many topics of interest. And thank you so much. If you have any question, yes, you can go through. Thank you so much.
Thank you so much, Dr. Elmoez. That was a wonderful presentation. The floor is open for anybody who has any questions to ask. I think there are no, are there any questions for Dr. Elmoez about his presentation? I think there are no questions. So thank you very much, Dr. Elmoez. That was a very good effort and a very good presentation.
Thank you.
We'll move on to our next topic, that's dementia. And for dementia, it's going to be presented by two doctors. The first part is going to be presented by Dr. Yaqot, and the second part is going to be presented by Dr. Hadeer. So you can start your presentation.
Hello, everyone. My name is Dr. Yaqot. Thank you so much for being here today, and I hope all having a great Saturday. And thank you, Dr. Nader, for this opportunity that you are giving us to prove and improve ourselves personally and professionally. So today we are going to talk about dementia, myself and Dr. Hadeer. So let me share my screen with you and let me know if you can see it. Can you see my screen?
Yes. Yes.
So I'm going to start the first part, and then Dr. Hadeer will help me out with the rest. So dementia, as we know, is a very major topic that we can see it in the elderly population. So we are going through some objectives that can clarify what's dementia and how we can go through evaluation of it, and what's the main etiology and risk factors that's associated with dementia, what's the differentiate between different types of dementia that might be mixing with depression, delirium, and also explore some personal, social, and financial impacts of dementia, and differentiate other types of different types of dementia. And then at the end, you are going to discuss the increasing awareness of the available community resources to help patients and caregivers for those who are suffering from dementia. So I'm going to cover the epidemiology, risk factors, assessment, and differentiation types of dementia, and then Dr. Hadeer will take over about the treatment and management. So what is dementia? In describing dementia, it's in general several disorders that cause significant decline in one or more areas of cognitive functioning. And it's severe enough to result in functional decline, which is important to differentiating it from the normal aging and also the normal cognitive lapses, which is clearly the patient will be fine on taking over all the functional of daily basis functions. So dementia is a progressive and dementia is progressive and disabling disorder. If you talk about epidemiology of dementia, studies found like 6% to 8% of people will start having the main dementia, which is Alzheimer, of age 65 years and older. And this prevalence is always doubling every 5 years, and nearly 45% or more of those aged 85 plus have Alzheimer dementia. The other part of dementia is the vascular dementia, and also one of the most common types of dementia, which is found to be 15% to 20% of the cases. And when it's found compound with the Alzheimer dementia, it's called mixed dementia. Dementia with Lewy bodies, it's also the second most common cause in people over 65. And we are going to talk about these specific types of dementia later in the slides. The impact of dementia, we have many separate types of impacts on the dementia. It's mainly economically and emotionally. So studies found that $818 billion will be annually affecting those who are suffering from dementia. Some of it will be covered by the Medicare, Medicaid, but they found that the main cost remaining with the families themselves, that going to paying more than $230 billion in the US specifically. So this is overwhelming economically, besides how the disease itself is overwhelming. And also emotionally, it's not only on the patient themselves, but also on the caregivers. They found that studies also found that the caregivers will be suffering from psychological distress, especially depression, and have more physical health issues by seeing the beloved one being vanished in front of their eyes. So it is a very overwhelming disease on many different aspects. If we talk about the etiology of dementia, the main etiology the study found relating to Alzheimer, let's say first, it's amyloid plaques, the tau tangles. In Lewy body, they found the cytoplasmic synuclein inclusion bodies, and in frontotemporal dementia, they also found the TAI or the ubiquitin proteins. We have risk factors and protective factors. So the main risk factors, we can split it into two different aspects, which is the definite, that something we cannot deal with it, which is age, family history, those people with Down syndromes, and also the presence of the ApoE4 allele. And there's some possible risk factors that we can, in some major aspect, can avoid it, which is the head trauma, fewer years of formal education, history of depression, and lifestyle and physical environment factors, and vascular risks. We have some protective factors. The definite effect of these protective factors is unknown, but some studies shows that if the patients like taking NSAIDs, there is studies found people normally with aging, they increase the cytokines levels, which is lead to inflammation in the brain. So taking NSAIDs like ibuprofen at some point will decrease or delay the aspect of dementia. Antioxidants, intellectual activities, physical activities that keeping the body and the brain in a very active process also decrease the presence of dementia. And also statin, some studies found that statin itself decreased the beta amyloid plaque that we see it in Alzheimer disease. Also, we can be using it as a protective measure and protective factors for dementia. Some type of dementia, it occurs genetically, and this comes in the early onset or the late onset of the dementia. So if the family history, like parents or other lineage of the family, they might have Alzheimer's disease in the family, this is going to be transported to the other family members. And this is occurred because of the presence of the amyloid precursor protein gene or the presenilin proteins, the PS1 and PS2. For those late onset, studies found also the ApoE protein gene, which is found on the chromosome 19. Those two alleles are the main cause of the Alzheimer's disease. And if we found the ApoE2 protein, this one is the protective. So those two is going to beat each other, either to forming or protecting from the Alzheimer's. Other studies with the genome-wide association found there's other types of genes that can be found just such as the chromosome 19, but they found it on other chromosomes like 12, 13, 14, 15, 16, and 18. All these factors will help for the development of the amyloid beta plaques that also be causing the Alzheimer's disease. And I'm going to share this study later of the presentation. So if we talk about the assessment of dementia, there will be many different ways. The main way for the assessment, and the first one, is when we communicate with the patient with their first visit in the clinic. So the history is very important and is very reliable informant about the patients for the case of date of the onset of the current condition, the chronology and the nature of the symptoms, medical history, any current medications and medication history, patterns of substance use or abuse, and living arrangements. All these questions in the history will help us to put the dots and connecting things together if the patient's having any types of dementia. For physical exam, mostly for the dementia, it's not very helpful unless if there's any neurological status. mental status that's physically and obviously can we find it and see it in the patients, and also for the functional status, but still we will go through all the examination for the patients to get everything included for our history taking and full exam. And also the most important things for the screening for patients with cognitive functioning is the mini cognitive, the slumps, all this stuff will just be talked later in the slides. And the scores that going to be recorded during these assessment is very important and helpful to assess the patients with dementia. For neuropsychological testing, when presentation is atypical, at this case, then we can go through the imaging or other type of assessment, defining the confound by a high level of education or subtle changes. So this is the screening instruments that most of the physician using it to evaluation the cognition part for the patients. We are going to talk about the first one is the mini cognitive instrument. Here we have to be scoring 2 out of 5, depending on domains that be assessing. It is the first one, the executive, if the patients like kind handling their daily basic daily life process, like financing, bank account. We ask them about recalling 1 or 2 like words or telling different types of naming substance, and also for the physiospatial part, where we ask the patient to draw or to write. Here we can assess the patient through the mini cognitive assessment. There's another assessment or instrument. It is the St. Louis University mental status. Here, besides what we do in the mini cognitive, we will be adding the orientation of the patient. If they are aware of the day, the date, where are they, adding the calculation, naming. If the patient scored 11 out of 30, then here this is a very low, and we can consider them as the beginning of dementia. The other assessment is the Montreal Cognitive Assessment. It's going to be the same as the previous 2, but here we are going to add the verbal fluency to see if the patient is fluent in talking to us and understanding the conversation. And here, if the patient is scoring 12, which is low regard of 30, then this is also considered as dementia. The Folstein Mini Mental Status Examination also will be talking about the orientation, the attention, recall, naming, repetition, the 3 steps command, and also the language and the physiospatial domains. And if the patient also scoring 19 is considered low and be diagnosed with dementia. The last one is the functional activities questionnaire. Here we are going to give the patient an informant-based paper, and is going to ask the patient about their daily life activities, if they can bathing themselves, cooking, preparing meal, and the executive functioning like managing their bank account, financing, concentrations, memory, and also home safety. And this is if scored 10, then we will the patient will be diagnosed with also dementia. In the case of laboratory finding, the lab work was not going to be very beneficial unless the other assessment came back negative, and we are thinking about specific like vitamin B12 deficiency, those people with HIV positive test, or neurosyphilis. So in this case, here we can depend on the lab works so that most of them can be manageable and helpful to treat the patients, and like reversible dementia, not it's a definite dementia. And in case of the neuroimaging, it will be the last resort for our assessment, especially if the onset of the disease occurs at age less than 65 years old, and the symptoms begin suddenly or progressive very rapidly, or there is evidence of asymmetric or focal neurologic deficits. The clinical picture suggests normal pressure hydrocephalus, and the patient has had recent fall or other head trauma. In this case, then we can go and consider doing a non-contrast CT scan, MRI, or PET scan if other diagnosis remains uncertain. For the functional evaluation for the patients, is very important for a patient with dementia. We go through the instrumental activities of the daily living and the activities of the daily living. So the instrumental is mainly going with the executive functioning of the patient that's related to the financing and bank account. The main thing about the activity daily, that patient can go to the grocery, carrying the daily functional activities easily, like cooking, bathing, making a phone calls. All these things important in our assessment for dementia. So important to know baseline level of function and to be able to differentiate functional decline due to cognitive impairment versus the other causes like patient with CVA. For cases where there is incongruence between functional status and assessment performance, we will consider doing the neuropsychological testing. So if we come to a diagnosis for the patient and we found out the patient is having dementia, it's not easy always to breaking the bad news to the patient and to the caregiver. So conveying the diagnosis can be associated with distress, but not definitely also associated with increased suicide risk. So healthcare professionals have the professional and ethical ways and sometimes legal obligation to disclose the diagnosis of the dementia for the patient and their relatives. We will have many types of dementia and differential diagnosis for dementia, starting from normal aging to the mild neurocognitive disorders and Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, delirium, depression, and other types of dementia that we are going to discuss it now. For normal aging, here, the mild decline in memory, it occurs, the patient, well, the normal aging is not a patient, it's just a physical changing of the normal elderly process. So here with the normal aging, we will see patient most of the time, or the people most of the time, like wearing notebook because they start forgetting easily. They want everything to be reminded and written, so requires more efforts and time to recall new information. Decline does not impair functioning, so they still having their daily activities, instrumental daily activities going smoothly, but with more efforts. The new learning, it might be slower than before, but it still occurs, usually well compensated with lists, calendars, and other memory supports. For the mild cognitive impairment, this is going to be subjective complaint of decline in at least one cognitive domain. Is going to be noticeable and measurable. So no impairment in independent living. The patient's still going to live normally, but most of those with mild cognitive impairment will have like 9.4 to 14.3 of 1,000 people will convert to Alzheimer's disease with higher in amnestic type. And 50% of the amnestic mild cognitive impairment maintain stable level of impairment or return to the normal cognitive status in 3 to 5 years. The neurocognitive disorders, this type allows for greater clarification around the diagnosis of the mild cognitive disorders impairment, and diagnosis of the mild neurocognitive disorder indicates also a measurable decline in one or more cognitive domains, causing the individual to use compensatory strategies in their management, especially for the instrumental activities of the daily livings. Alzheimer's disease, which is the most common type of dementia, the onset of this disease is going to be gradually. The memory impairment core feature with difficulty learning new information, language, and physiospatial. The motor symptoms is rarely to be found, but apraxia occurs later. The progression, it's gradual, as we mentioned, and it goes over 8 to 10 years on average. The lab test will be normal, but imaging will show us possible global atrophy and small hippocampal volumes. Vascular dementia is also the most second common type of dementia. This type, it may occur sudden or stepwise. It depends on anatomy of ischemia, but this executive deficits and slowing common also will be presentable. As we mentioned, it correlates with ischemia, and it's going to be stepwise with further ischemia, the progression of this disease. The lab test will be normal, and the imaging will be cortical or subcortical changes on MRI. Dementia with Lewy bodies, the onset's going to be gradual for this disease, and the memory and the visuospatial and hallucination and fluctuation symptoms will be very obvious and can be recognizable. The patients will present with Parkinsonisms, and the progression is going to be gradual, but is going to be faster than the Alzheimer dementia. Imaging will show a possible global atrophy. For the frontotemporal dementia, mainly this one occurs usually less than 60 years old. At this cognitive symptoms, there will be more impairment and disinhibition, apathy. This is going to be affect the executive, daily living, language, and plus minus the memory. Some of the patients will be present with some rare genetic forms associated with ALS, but some of them also present with normal motor symptoms, with negative motor symptoms. The progression is going to be gradual, but faster than Alzheimer's, and the imaging will show atrophy in frontal and temporal lobes. There is a very misconception between delirium and dementia, and sometimes we get confused, is this patient having delirium or dementia? So there's distinguishing signs of delirium that we can easily find it. The delirium mostly occurs for the hospitalized patients with acute onset. The cognitive fluctuations, it's occurred throughout the course of the day. Like the patient in the morning might be fine, and then in the afternoon you will see some cognitive disabilities. There will be impaired consciousness and attention. There will be fluctuation of the level of alertness throughout the day, and also alteration of the sleep cycles. We always search for any delirium cause, and if we diagnosis with delirium at the end, delirium is cleared, we still have to look for any dementia, underlying dementia. For depression, most think for depression patient will be primary dementia, commonly experience symptoms of depression, but still those with depression will have also significant symptoms. That we know it in demonstrating decreased motivation during the cognitive testing and express cognitive complaints that exceed measured deficits, but they still have maintaining an intact of the language and motor skills. And also there will be a family history of depression. And 50% of the presenting with reversible dementia, and most of the patients with depression, they will be progressed to dementia within 5 years. So any patient with depression comes into the clinic, we have to keep asking each visit, making sure that the patient is cleared from the dementia or from depression, or they are going to expressing any new symptoms of like memory lack and something related to dementia. Last thing we have is staging of dementia. So it's not easy to diagnose dementia in clinic, especially if the patient walk in the clinic with one of the first, second, and third stage of the dementia. Mostly the patient will not telling us that they have dementia, and also we related on the caregivers and the family members, because they are going to notice any changing in the memory or the impairment of the patient, and they are going to expressing those concerns to us in the patient's visits. So the stage 1 is the no cognitive impairment. In this case, the unimpairment individuals experience no memory problems, and none is evident to a healthcare professional during the medical interview. The second stage is very mild cognitive decline. In this case, individuals at this stage feel as if they have memory lapses, which is one as the normal aging, especially in forgetting like familiar words or names or the location of keys, eyeglasses, or other everyday objects. However, these problems are not evident during the medical examination or apparent to friends, family, and or co-workers. The third stage is the mild cognitive decline. This occurs mostly in the early stage of Alzheimer's disease and can be diagnosed in some cases, but not all individuals. friends, family, or coworkers begin to notice these deficiencies, and problems with memory or concentrations may be measurable in clinical testing or during a detailed medical interview. The stage 4 until we go to stage 7, this is going to be a kind of a cutting edge that can be visibly and noticeably found in the clinic. So stage 4, moderate cognitive decline, mild or early stage Alzheimer's disease. At this stage, a careful medical interview detects clear-cut deficiencies. The affected individual may seem subdued and withdrawn, especially in socially or mentally challenging situations. So stage 4 will be easily noticed in the clinic visit. Stage 5, which is moderately severe cognitive decline, this is occur in moderate or mild stage of Alzheimer's disease. Major gaps in memory and deficits in cognitive function emerge, and some assistance with day-to-day activities will be needed and becomes essential. Stage 6 is severe cognitive decline, where moderately severe or mid-stage Alzheimer's disease. In this case, memory difficulties continue to worsen. Significant personality changes may emerge, and affected individuals need extensive help with customary daily activities. And lastly, stage 4, where very severe cognitive decline occurs, and this occurs in severe or late stage of Alzheimer's disease. In this stage is going to be the final stage of the disease, when individuals lose the ability to respond to their environment, to speak, and to ultimately control their movement. So this was a main overview about dementia. And if you have any question, I'm happy to answer it. And next slides will be presented by Dr. Hadeer.
I have a question.
Yeah, sure.
Yeah, first, thank you for this comprehensive presentation.
Yeah, sure. Thank you.
My question is, it's just I'm curious about the risks of the risk factor of dementia. I don't know which slide, maybe just a few slides.
Was it?
And yeah, you mentioned that one of the possible, on the top of the possible protective factors is non-steroidal anti-inflammatory drugs. I'm just curious, is this like a conclusion of some literature or studies?
Right. So,
And is it, and if so, is it like, does it mean like the use of non-steroidal anti-inflammatory drugs, the history of use will decrease onset or progression of dementia, or using it after the onset of dementia will decrease progression?
So those are one of the protective factors, which is the onset. So studies, it's showed that on animal level studies that with the aging, the brain will be processing increasing the level of cytokines, and this is increase the level of inflammation and will progress for dementia. Let's say with the old aging processing. So the study is not like 100% they are sure about the onset, but like on the animal side, they found the onset is decreasing the process of cytokines and decrease the inflammation of the brain. That is the main, maybe related to dementia, but they are not 100% sure of that one. So it's only research basis, but clinically they didn't prove it actually.
Okay, thank you so much.
Mm-hmm.
Thank you, Dr. Yaqot. That was a very good presentation.
Sure, thank you to you. Okay, I'll just stop sharing my screen so that Dr. Hadeer can take over, if that's cool, okay?
Yes, that's perfect. Are there any more questions for Dr. Yaqot? I think we can move on to Dr. Hadeer for the next part of the presentation.
Okay, thank you so much, Dr. Yaqot, for this informative presentation and walking us through, the dementia as it's getting more with especially, nowadays. We will continue with the treatment part. I'll share my screen shortly. So are you able to see it?
Yes.
Okay. So here we will talk about the primary goal of treatment. So actually we have, so the actual treatment for dementia is not very, successful. It's actually like a chronic progressive disease. So we just, treat for the sake of symptoms and to decrease the symptoms as much as we can. So the demented patients are usually seen by geriatricians, by neuropsychiatrists. Usually the primary care will just, need the help of even non-medical specialties like the social workers can help with the management of these patients. So the goal for treatment actually for this type of patients with dementia is to enhance the quality of life, like how much they can do daily, the functions like can they dress themselves, can they feed themselves, the basic life needs of the daily living, like Dr. Yaqot mentioned. So we have three things that we have to enhance while doing this. We enhance the cognition, the mood, and behavior. These are the three main things that we work on while we are starting the treatment. So let me do this better. Okay. So for the cognition part of the treatment, we have to do like cognitive training. We have like group therapies, like a group of demented patients that sit with each others with like a psychotherapist, and they kind of do the therapy for them. There's we increase physical and mental activities as Yaqot mentioned before. That is kind of protective factors. And also for the caregivers and the family members, we have to educate them and support them on how to, support the patients, how to, make them more functioning on the daily living. And most importantly, we have to have attention to the safety. We need to know that this patient is supervised, that there are no much falls, they can, sometimes drive or wandering, or they might be lost in the streets. So we have to avoid these, things if they are having like moderate or severe dementia. So we have to also inside the house, we have to do like certain kinds of environmental modifications inside their houses, like, supportive strategies like we use clocks, calendars, to-do lists to make it, more easy for them to manage their daily living. And also, you have to make sure that the house is free of, safety issues that might lead to falls, or like there shouldn't be like sliding surfaces like, carpets or things that they might fall from. And of course, treatment has to be individualized according to patients. So not all patients are like each other's. Each patient is different. Like we have like 7 stages of the disease. We have to categorize the patient and, know which treatment he will benefit most from. So for the medical treatment, the most thing that is used is the cholinesterase inhibitors like the donepezil, rivastigmine, and galantamine. Of course, you've heard about them before, but actually in real life, they are not of much, help in treating these patients. We're usually just slowing down maybe the progression or symptoms. And we will talk now about the side effects, because they have like severe GI side effects that might be when we know, say, the risk versus benefit, we might see that the GI symptoms, side effects from these treatments, from these medications, might be more actually from the benefit. And also, if the mood is the most affected part, like if the patient is having depression, we use the antidepressants like SSRIs, these kind of stuff. And there are also psychoactive medications that can be used. So for the, I'm not sure if you can see this. So for the cholinesterase inhibitors, we usually use, so how it works, it basically slows down the breakdown of acetylcholine. So there are more acetylcholine in the body. The trials demonstrate that there is, modest delay in cognitive decline compared with placebo in Alzheimer's disease. But as we said before, the GI side effects are very common. So they usually have like diarrhea, vomiting, abdominal pains. And so the maximum dosing that we can use of, for example, donepezil is 23 milligrams per day. And this creates significant side effects without evidence of improving the global function. And no evidence of difference in efficacy among drugs. So most of the anticholinesterase drugs, mostly they work the same. There's no one, no one medicine is better than the other because they have the same method of action. The use in other kind of dementias other than Alzheimer's, the widespread use in vascular dementia, for example, is not actually recommended. And attention and behavioral disturbances in Lewy body dementia can benefit from treatment. So these can benefit especially in the Lewy body dementia. Rivastigmine is FDA approved for mild to moderate dementia in patients with Parkinson. Treatment in frontotemporal dementia may actually worsen the agitation because this kind of patients usually have agitation, and the treatment might actually worsen it. Okay, so now we're gonna do. Sorry about that. Oh, the memantine is the effect of it is to reduce the glutamate-mediated excitotoxicity. It has modest, benefit on cognition and behavior in Alzheimer. It has limited effect on cognition and no evidence to support widespread use even in vascular dementia. It's actually FDA approved for moderate to severe Alzheimer's dementia, so we don't use it in mild to moderate. The common side effects also are like constipation, dizziness, and it might cause headaches. So there are other cognitive enhancers that might, enhance the cognition, like vitamin E. It's but it has not been, the clinical efficacy and safety of vitamin E has not been fully established. Silogylene may lower the rate of functional decline, but no evidence also on cognitive improvement in Alzheimer. And, the over-the-counter things like ginkgo biloba, these stuff, they actually don't have any benefit in slowing the cognitive decline. So what I just through my search, I found that there are lately in 2021 there was a newly FDA approved medicine. As you heard, like the monoclonal antibodies medicines are nowadays, in every kind of disease. There are many studies on them, even not dementia, in other diseases. And actually, they found that there's kind of medicine. It's called the aducanumab for treatment of Alzheimer's disease. They proved that it can work with mild cognitive impairment in Alzheimer, and actually they said there was improvement. However, the insurance company, as any new drug that is in the market. Not all insurance companies will just sponsor it, so it's not widely used. However, that they said that they found some kind of cognitive improvement, especially in mild to moderate Alzheimer's disease patients. And also a very, recent one in 2023, it's called the lecanemab. And but the drawback for this, it's that its method of you give it by IV in the arm. So, and it's not in the market. It's in phase 3 now, clinical trial. And they found that it decreased in early Alzheimer's disease, it decreased the cognitive decline by 27%. So I think it's promising because 27% is not small. So hopefully it will be in the market, in the early future and can be used and benefit these patients. So back to the slides for the symptom management, as this is the most important thing that we are working on. It's not because the treatments that are widely used are not very beneficial. So according to the symptoms of the patient, for the psychoactive medications, when there are behavioral disturbances in the patients, it's best managed, as we said, non-pharmacologically, like by reducing the overstimulation, by environmental modification around the patient. However, when meds are required, the symptoms should be identified and therapy should be selected according to the symptoms that the patient is having. We said that if the patient is showing like mood disturbance in the form of depression, like there's fatigue, insomnia, irritability. So a high dose of citalopram, it showed significant improvement in behavior, but also it showed worsen in cognition and QT prolongation. So we have to be careful, because there are these side effects. So we have to see the benefit versus risk. And, as we said, it's individualized according to each patient. Each patient is treated differently. So we have to see if the benefit will be, overcome the risk. And actually, as we said, we have to have caution. Falls and anticholinergic effects that may worsen the confusion, like paroxetine, can cause these. So we have we can use also the first and second generation of antipsychotics. However, limited evidence of efficacy and increased risk of all-cause mortality in dementia. It should be used with caution. And usually we use it when the patient is experiencing delusions, hallucinations, irritability. So, and we always, when you use antipsychotics, as you know, it has multiple side effects. So we have to, taper it off slowly from the patient. And we have valproic acid and carbamazepine are possible options, but with limited also evidence and increased risk of mortality. We can use benzodiazepines, especially if the patient, is having trouble sleeping and is insomniac. And the use of both with each other actually should be avoided. So when we have a demented patient, whom should we, think of like a specialist that we can refer this patient to gain more benefit? We can refer to geriatric psychiatrist or neurologist or neuropsychologist, actually for non-medical, people that can help, like the social worker, physical therapists, And of course, we have these patients have to have a will, because later on you don't know down the road how these patients will for their cognition and memory, they might be not able to do it. So whenever a patient is in early disease, we have to suggest having a will. And for the the neighbors, the family, friends, and networks, the community itself, these are kind of resources for managing the demented patients. There are also organizations that can help these patients, like the Alzheimer's Association, area agencies on on aging. They might need, you know, services, especially if they don't have like a caregiver living with them, like Meals on Wheels, senior citizen centers that might be of help for these patients. And so when choosing like a treatment for our patient, we have to choose wisely, as we said. So when we prescribe, for example, like cholinesterase inhibitors, because these are the most widely used medicines for dementia, we have to do like a periodic assessment for the cognitive benefits. Is the patient actually benefiting from this treatment, or he's just taking it and there's no benefit? We have to ask about the GI side effects. Is he experiencing it? Is he, you know, having trouble with it? So we have to do like periodic follow-ups with these patients. And of course, as we said, the antipsychotics have many side effects, and we don't use them, you know, widely, unless the patient is having like hallucinations, delusions, and these type of symptoms. So because they have many side effects. So as a summary of Dr. Yaqot's and mine, so we know that dementia is common in older patients, but it's not an inherent part of aging. Like not every, you know, elderly must have dementia. No, it's not like that. Alzheimer is the most kind of common type of dementia, followed by the vascular and dementia of with Lewy bodies. Evaluation of these patients include like history with, you know, physical and functional assessment, focused labs, and possibly brain imaging. However, usually the history is enough. And the primary treatment goals are to enhance the quality of life of these patients and maximize the function by improving cognition, mood, and behavior. Treatment may involve both medical and non-pharmacological interventions, as we said, and there are many community resources that might help and support these patients and their families. So now we will start with cases. I will appreciate if you guys can put your answers in the chat. For case number 1, it's about a 75-year-old man is brought to the office by his wife because he has had progressive cognitive and behavioral decline for the last 3 years. The wife says that his memory, attention, and organizational ability have declined, such that his daily function is impaired. So this is important to take notice of. The patient says that his sense of smell has decreased. This is another clue. He has had progressive weight loss. He has acted out his dreams for many years. This is a very important clue, actually. And more recently, just a moment. He has behavioral disturbance that is worse at night with frequent delusions and intermittent hallucinations. Okay, so which one of the following clinical features is most useful for differentiating dementia with Lewy bodies from Alzheimer's disease? So as I mentioned, there were several clues mentioned in the question to figure out if it's like Lewy bodies or Alzheimer's disease dementia. So the answer options are, is it psychosis? Is it the hyposmia? It is the memory impairment, or if it's the REM sleep behavior disorder. So only one of these is mostly to differentiate between the Lewy bodies and the Alzheimer's disease dementias. So I'll give you just 30 seconds to answer. What do you think would mostly differentiate? Okay, so I think most people chose like D, and this is actually correct. So actually the answer is D, the rapid. So as we said in the question, that the patient had multiple acting outs while sleeping, because these patients have like, they usually have like dreams that they have like muscular, that increases their muscular activity. They might have like, they might Their wives or family members might notice that while they're sleeping, they act out their dreams. They can actually fight whoever is next to them, something like that. And as an additional thing, it usually happens with Parkinson. So here's another case. It's an 82-year-old man is seen for his annual wellness visit. His wife says that his thinking has slowed in the last 2 to 3 years, and he does not focus as well as previously. Reminders does help, but he can no longer manage household finances. And sure. Sorry. Oh, okay. He has no longer can manage the household finances or organize his medications without assistance. He has insight into his deficits. He has a history of hypertension, diabetes, coronary heart disease, and prior stroke. Examinations shows mild left facial droop, mild left arm spasticity, and pronator drift without overt weakness, and hemiparetic gait. The lab findings, the creat is within normal, the hemoglobin is 12.8, mildly anemic, the hemoglobin A1C is 7.8, it's high, TSH, vitamin B12, HDL cholesterol, LDL cholesterol are within the mentioned numbers. MRI of the brain showed moderate bilateral white matter hyperintensities on T2, flare sequences with evidence of several chronic lacunar infarctions. Okay, so which one of the following is most likely to improve the cognitive outcome over time? What do you think will help mostly this patient? So is it the exercise program or omega-3 fatty acid supplementation? Is it the cholinesterase inhibitor or is it statins? I'll give you a few seconds to, think about it and think which will mostly benefit this patient. So the answer is the exercise program is mostly to help this patient. So this patient is actually hemiparetic, as we said, and mostly had like an infarction, strokes. And, it says that exercise program and maybe physical therapy will mostly help this patient and improve his cognitive outcome over time, because this is not like Alzheimer. And as we said, cholinesterase inhibitor is not of much benefit. So here's the third case. 76-year-old woman comes to the office to establish care. She has had progressive cognitive and behavioral decline over several years. The patient cannot provide sufficient information. Her family describes impaired function. They are not sure how much is due to decline in cognition and how much to loss of interest in activity. She has no other symptoms of depression. She has no delusions or hallucinations. On examination, she displays poor memory and concentration. Language function seems to be intact. The patient has limited awareness of her deficits. Testing is limited by impulsivity. Lab findings are unremarkable, and when an MRI of the brain was done, there was mild white matter changes and moderate diffuse atrophy. No evidence of stroke or mass lesions. Which of the following imaging modalities should be done next to establish a diagnosis? So is it like dopamine transporter single photon emission computer? I mean, it's SPECT, or is it FDG PET, or if it's MR spectroscopy, or is it R SPECT? So we'll just wait for a few seconds for your answers. I know it's a hard question. So actually the answer is fluorodeoxyglucose positron emission tomography. So it's kind of a PET scan. So that would be the most beneficial thing for her. You know, just to minimize the cause and to know actually what is the real cause for that. So, and thank you. So this is the end of our presentation on dementia. I hope you guys benefited from it. I'm sorry?
About the activity that you were saying. So,
Your voice is, I think your voice is kind of breaking, so I'm not sure if it's only on my side or everyone is not hearing you quite.
Yes, Dr. Arshad, your connection, your connection seems to be getting a little weak. You're breaking up.
I was telling about FTG.
You can use the chat if you can try from the chat. Dr. Arshad, maybe
Yes, sir.
use the chat.
I'm sorry. Hello.
Yes, we can hear you now.
Yeah, I was talking about the FTG PET in these patients. So it is the uptake by the highly active cells by the glucose uptake. Mostly we do this, we use PET scans it for the metastatic lesions, but in Alzheimer's disease, we do FTG PET, and it's high uptake of the amyloid cells in these patients as well.
Dr. Arshad, you're breaking up again.
Yeah.
Would you be able, if you're having trouble with your internet, could you be able to write your question on the chat box?
Right.
Thank you.
I think what he was trying to say is that the PET scan, the last answer for case 3, they use it in cancer patients. So you want to identify if they have metastatic lesions and so forth. But this when using the glucose, it will use the activity as well, like the cell activity. So you want to see in the brain if the cells are active consuming this glucose. Thank you. Thank you all the presenters. Go ahead for any other questions.
Thank you so much, Dr. Hadeer, for the presentation. I actually wanted to ask a question. So you mentioned I'm just curious to know that you mentioned when treating a patient with dementia, one of the environmental changes that have to be made are if we have to change the clock in a person's environmental setting. If you could go back to that slide.
Oh, just a moment.
So I'm just curious to know if why would we want to change the clock when we're treating when we're setting up an environment friendly for patient with dementia.
Sure, yeah. Yeah, I know what you're talking about. They just mentioned that one of the, I mean, environmental, yeah, this one, that like might support these patients is like the use of clocks. So I mean, if they're having breakfast, for example, like 7 in the morning, and there's a clock in front of them, so they have to finish this breakfast maybe by like 30 minutes or so. So from what I think is that the clock might help them when it's 7:30, that they have to be done by the job they're doing, calendars, just to make them organized. I mean, calendars like each day you have to do this, like this day you have to do grocery, this day you have to clean, or, you have to take a bath on this day. To-do lists, it makes life easier and it makes life more organized, especially with people with cognitive impairments, that, they might, not be able to think about the time that it's going by, or think about the days that's, oh, today is Monday, so I have to do this. Oh, today is Tuesday, so I have to do this and this. Also, the clock makes them more organized. They have to do special things within, certain times. So it's not like the day is not like the night. No, they have like clocks. There is certain time where the patient has to go to sleep, the patient has to eat, the patient has to do this and this. So it just, these things would help a little bit with keeping the patient organized and knowing what to do on a daily basis and on a time basis. So that's what I think about. It might be of help for these kind of patients.
Interesting. Thank you so much for clarifying that.
You're welcome.
Are there any questions anybody would like to ask? So we have a message. We have a message from Dr. Arshad on the meeting chat, which is visible to everybody, but I'll still read it out. He was trying to say that my input was by doing FDG PET, we tried to see amyloid buildup and is the hallmark of Alzheimer's dementia.
Oh, interesting. Okay.
Thank you
So
very
it's
much.
not actually for like metastases or primary malignancies of the brain. It's actually for Alzheimer's. So yeah.
Yes, that's a very interesting point.
Okay.
So thank you very much, Dr. Hadeer. That was a very good presentation.
Thank you.
Are there any questions from anybody to ask before we move on to the next presentation? Okay. Thank you very much. I think we'll move on to our next presentation for the day. It's going to be on organizational skills. That is by Dr. Ali Shata.
Hello, everyone. Good evening.
Good evening.
I think everyone can see my face and hear the voice good?
Yes.
Okay. Dr. Hadeer, can you please stop sharing your screen so I can share my screen? Okay, assalamu alaikum. I would like to thank you all for being here today. And I would like to thank Dr. Nadim for giving us this opportunity on improving ourselves personally and professionally, and being able being within a community that helps us to improve. So I would like to present a session about organizational skills. My name is Ali Muhammad Shata. Okay. The objectives of our session is to define first the organizational skills and to emphasize the importance of organizational skills in personal and professional success, and also to explore key strategies and techniques to enhance our organizational skills. So to the definition of organizational skills are defined as the ability to efficiently and effectively manage time, resources, and tasks to achieve goals. Okay. So in other words, it's the way of getting the best job done while spending the least time, efforts, resources, and time on it. Okay. So organizational skills include various elements such as time management, prioritization, planning, and decluttering. Okay. The main benefits for a strong organizational skills
The first thing is to improve productivity. Organized individuals can accomplish more in less time. Also, it reduces the stress. Being organized minimizes last-minute rushes and enhances the overall well-being. Also, it enhances our efficacy, since being organized will streamline the workflow and optimize resource allocation. It also gives us a better time management, since prioritizing tasks and allocating time effectively leads to optimal use of time. Also, it improves our decision making. We can access information quickly and make informed choices. For the key strategies for developing organizational skills, we have three main strategies. We have time management, we have prioritization and planning, and the third one is decluttering. We will go through each one of them. For the time management, we have to set clear goals and objectives. We have to prioritize tasks based on the importance and urgency, which tasks should be done first, which tasks are time limited. We have tasks that need to be done in a certain time limit, and other tasks that can be delegated to other people. We have tasks that can be scheduled to another time. Okay, we can make use of the time management tools like calendars, to-do lists, and reminders. Also, one of the most, actually, one of the things I found to be very effective in organizing time or in having organizational skills at all is practicing and understanding the rule of 80-20, which states that in every situation, about 80% of the outcomes are influenced by only 20% of causes. So what does this mean? Like, if you have certain disease in our medical practice, usually this disease is influenced mainly by about 20% key risk factors. So if you tackle these 20% key risk factors and you spend your time and effort and money on these factors, you will get the benefit to about 80%, rather than just trying to spend your time and effort to get to the 100% of the risk factors. If you just focus on the main risk factors, like the 20% of these risk factors, you will get to about 80% of the outcome. Also, we avoid multitasking, and we dedicate specific time blocks for focus work. The second key strategy is planning and prioritization. We can break down large tasks into smaller, manageable ones. We create a daily and weekly plan to outline tasks and deadlines. We allocate time for planning to the start of each day or week. We use prioritization techniques like the Eisenhower matrix. The Eisenhower matrix is like a box that has 4 points or 4 aspects. So we divide our tasks into urgent and non-urgent based on the time limit. So urgent tasks that are tasks that need to be done in a certain time limit and need to be done as quickly as possible. Non-urgent tasks are the tasks that they don't have to be necessarily unimportant, but they don't have a certain time limit. So if you have an urgent task that is important, which are tasks that need to be done quickly and immediately, because they will have severe consequences on our goals, on our ambitions. These tasks need to be done immediately. Okay, for example, picking your kid to the school, for example, submitting a draft article, for example, finishing a certain article. These are things that need to be done now and need to be done by you. Also, the other thing is urgent tasks, but non-important. These are tasks that needs to be done, but you can refer it or delegate it to someone else to do it for you. For example, meal prepping, for example, scheduling. These tasks are urgent, but you can delegate it to someone else. You don't need your set of skills to do these tasks. The other things are the non-urgent tasks. If you have an unurgent task but an important task, which are tasks that need to be done, but there is not a set time limit for it, you can schedule it for later. You have to do the important things first. For example, like exercise, networking, professional development, all these things can be scheduled for later. The fourth component of the Eisenhower matrix is the non-urgent, non-important tasks, which are not necessarily distractions, but can be stuff that they will not, let's say, they will not push you toward your goal. But if you have them in a small moderation, they can be okay, like social media, like video games, like watching TV, or eating junk food. Okay. The third key strategy and organizational skills is decluttering and organization. We have to maintain a clean, organized workspace. We have to develop a filing system for physical and digital documents, regularly declutter and remove unnecessary items, use digital tools for organizing files, notes, and emails. The main thing that we are looking for is having organizational skills as a habit. We don't want to just reach the point of having organized skills and just forget about them, just have being organized for one project and then forget about it. The goal here is to have the organizational skills as a habit. So consistency is the key. Practice organizational skills consistently to develop them as habits. Start small, focus on one area at a time, and gradually expand your organizational efforts. Reflect and learn. Assess your progress regularly and identify areas for improvement. Seek feedback and guidance from mentors and colleagues. Like any new skill or a goal, you will be faced with challenges. You have to overcome these challenges to reach your goal and your skill. Some of the common challenges for being an organized person. The first one is distractions. To overcome that, we have to create dedicated work environment and utilize productivity tools. The second thing is lack of motivation. Okay, we should break tasks into smaller, more manageable chunks and reward ourselves upon completion. Information overload. Implement strategies such as information filtering, batching, and using productivity apps. Procrastinations, which I think is the main one, is the most challengeable thing. To overcome that, we have to set deadlines to combat procrastination and also use techniques like the Pomodoro technique. The Pomodoro technique outlines that to do a certain task and to stay mentally fresh and not get exhausted or overwhelmed with the task. The first thing, you pick the task, you set a time of 25 minutes. You keep doing that task for the 25 minutes, and then you take a 5-minute break, okay, to refreshen up, and then you come back to tackle that task for another 25 minutes. Then you take a break for 5 minutes, and you do that for 4 cycles, and then you can take longer breaks. This technique helps us to stay mentally fresh and you stay focused, so you will not be overwhelmed with the task and get bored or tired with it. I'm presenting some cases of success that outlines the importance of being an organized person. The first one is Dr. Atul Gandhi. Dr. Atul is a renowned surgeon and a writer and a public health researcher. He's known for his exceptional organizational skills, okay, that allowed him to excel in his medical and personal career. Okay, he has authored a book that is called the Checklist Manifesto, which outlines the importance of having checklists in surgeries, in patient safety, and all of that. Also, another example is Elon Musk, which is known for everyone, I think. He's the CEO of Tesla, SpaceX, and he has many ventures and companies. He's also very known for being very organized and being meticulously scheduled. He has a schedule for everything. Also, I can make a case here for our mentor. I can make a case here for our mentor, Dr. Nadir. I am sure that he has a very meticulous schedule. to being organized, and to being able to help us with our research fellowship and professional life and his personal life. So in the conclusion, we have to know that being organized and developing organizational skills is important for personal and professional life, and that anyone can develop and improve their organizational skills with practice and commitment. We should start taking actions today and apply these strategies and these techniques. Thank you, everyone, and I would be very happy to answer any of your questions.
Thank you, Dr. Ali. That was a very good presentation. Are there any questions for anybody, from anybody for Dr. Ali?
Thank you once again. Also, a great presentation. Thanks, Dr. Ali. Thanks to all the presenters.
Thank you, Dr. Nadir.
I appreciate it. I think it's important to know that when you enter residency, you will be faced by different tasks. As a junior, you will be run by the seniors, and they will ask you to do this, do that. And at the same time, you want to read, you want to study, you want to prepare maybe for the morning rounds and case presentation. So you have to be organized. And in second year, you will be the senior. You will have some present under you, and at the same time, you will be working on getting your. If you are applying for a fellowship, for example, you want to get more information. It's going to be hectic, so you need to be very organized to be efficient. But yeah, thank you so much. I appreciate it.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir. That's a very good point. And I just want to say, Dr. Ali, that was a very good presentation, especially the Eisenhower graph that you shared about prioritizing your tasks. That's very helpful, and that's definitely something I'm going to keep in mind.
Yeah.
So are there any other questions from anyone, or should we move to the next slide? I think there are no more questions for you, Dr. Ali. Thank you so much. So we'll move on to our next presentation for the day, and that's on organizing your digital files, and I will be presenting that. So I'll just start sharing. I'll just start sharing my screen. Let me know if you can see if you can see my screen. Okay, I think it's visible. Hello, everyone. My name is Dr. Saba Irfan, and today I'll be presenting on organizing your digital files. And it's basically somewhat of a comparative presentation, but comparing two of the bigger cloud storage spaces, that is the Google Drive versus Microsoft Outlook's OneDrive. Starting with Google Drive. So before we proceed, I would like to talk a little about the cloud storage space. It's basically an online space where you can save all your files, your pictures, your if there are any videos, and it's not a physical space. It's an online space, so you don't really need a specific laptop or a PC to access it. So the best part is that you can access it once you have an internet, and you can access it from anywhere. So that makes sharing and managing your digital files very easy. So we'll first talk.
Sorry, Dr. Saba, we didn't see the screen.
Oh,
sorry.
The screen is just frozen.
Can you see it now?
Not yet for me.
No. Let me try sharing it. Sorry about that.
Yeah, you're good. Yes.
Is it visible? Okay, sure.
It is. Thank you.
Yes, thank you.
Thank you for letting me know. So we'll start with Google Drive. It's basically a cloud-based storage service that allows you to store and share files online. It offers about 15 gigabytes of free storage space, which can be upgraded to up to 100 GB for only $2 per month. Google Drive is a great fit for organizing files that you want to access from anywhere and share with others. You can also use Google Drive to collaborate on documents with others in real time. So it's basically it's a cloud space that is that has been created by Google. So it makes things very accessible and easy to manage. Since it has been created by Google, it supports only most of its Google documents. So the documents that you can easily use and they're compatible with the drive are Google spreadsheets, Google Notes, Google Documents. It's not very easy to collaborate your Microsoft documents or your Microsoft applications. For that, we usually end up using OneDrive. Now talking about how to create a folder in Google Drive and how to share your folders with anybody on your search list. This is a quick picture that I got from the internet. I'll give you a preview of how to create a folder on your Google Drive and how to share it with anybody in just a little while, but we can just go through the picture first. This is how the overall outlook should look like. You just click on new, you create a folder. Once you have a folder, you're going to name it. And once it's been created, once you've created the folder, you can start sharing it. Again, you click on it, there is a share option, and you can just put in an email ID, or you can actually share the link to that folder with anybody via email or through messages. While sharing, there is another option, that is the editor option. You have the liberty of allowing the person to edit, that is organize or make changes to your folder and your file. Or if you just want to leave it on the viewer only mode, you can do so. That way, the person you're sharing your files with, they will just have the autonomy and the accessibility to view your files, but they cannot make any changes or any additions or subtractions to your files. And once that is done, that is how you're going to create a folder and share on Google Drive. Now talking about the second part, the second type of cloud-based storage for storage that is very commonly used. It's a Microsoft Outlook OneDrive. It's as the name suggests, it's created by Microsoft, so it's very compatible to the Microsoft Office. It has a built-in Microsoft suite, so basically you will have access to Microsoft Word, Excel, PowerPoint, and so you will essentially be working with those files. You can, and it is it's an email client that comes with Microsoft Office. It allows you to organize your emails, contacts, and calendar in one place. Outlook also has a built-in file storage system called the OneDrive that allows you to store and share files online. OneDrive offers about 5 GB of free storage space that can be upgraded to 100 GB for $2 per month. Outlook is great for organizing files and are related to your emails or calendar events. So it kind of syncs your Hotmail account with your calendar, and it puts everything on your calendar that's going to be present on your Hotmail account. That includes any meetings that you might have scheduled, any upcoming appointments. So it's easier if you are someone who's been using Hotmail account or who uses Hotmail account, it's easier for you to have OneDrive because that kind of puts everything in one place. And as far as the Google Drive is concerned, it can kind of puts all your Gmail. If you have a Gmail account and if you're comfortable using Gmail, Google Drive puts everything that's in your Gmail account at one place. So now how would we create a folder and make share a folder, share our documents with anybody in our contact list with OneDrive? It's pretty much, it's very simple. This is how the Outlook looks like. Once you've clicked on file, you make a folder, you create a new folder. Once you've created a folder, it's going to appear this way. And as you can see, it says private. That means if it says private, that means nobody else can has a visibility to it. You can allow access by clicking clicking on manage access, and then you can add whomever you want to add. One good thing about OneDrive sharing is you have the ability to, when you're granting access, you can add passwords to it, which kind of gives an extra security to your files and to the whole sharing when you're sharing your files, and if there is some sensitive information that you don't want anyone else to access it, you can actually keep passwords and you can just share it with pertinent individuals. Secondly, there is also an option of expiry date. For instance, if you're working on a project that's going to end by the end of the month, and you don't want to keep any records of it, or maybe you you don't want to, maybe it's some private information you don't want to keep access to, you can keep an expiration date when sharing the file for 1 month, and the document will automatically get deleted from your drive after the end of that month. It's really good in a way that sometimes we have old documents in our files and we never go back and to delete it because sometimes you forget, sometimes things keep on piling on. So this is something I think that's a very good aspect that you have for OneDrive sharing, that allows you to keep your drive extremely clean and without keeping old documents that you may not be using as much. Now, if we were to compare Google Drive versus with OneDrive, we'll just so the Google Drive allows you to collaborate on documents with others in real time. It integrates with other Google services such as Gmail and Google Calendar. It can be difficult to integrate with other forms of communication such as Outlook. So it's a little difficult and gets a little complicated if you're trying to put down your Microsoft documents in your Google Drive. You can do it. It can get uploaded, but since it's more easily compatible with Google documents, it takes a little bit of time uploading it and working on them. It can be difficult to get everyone to start using it. It cannot password protect when collaborating, and there are no expiration date features when sharing files for a project. Whereas if we were to talk about OneDrive, it comes with the built-in Microsoft Office. It allows you to organize your emails, contacts, and calendar in one place. It has a built-in storage system called OneDrive that allows you to store and share files online, and it has a complete Microsoft Suite integration that includes Microsoft Word, Excel, and PowerPoint. And I would also like to give you, show you how to create, how to make a file and how to share in real time. So as you can see, this is my Google Drive, and this is how it's supposed to look like. This is how the whole Outlook is supposed to look like. So let's say I was to create a new folder.
I'm sorry, I think you need to stop sharing and then share again.
Oh, can you see it now? Wait, let me. Is it visible? Is my screen visible to everybody?
Yes, for me, yes.
So this is my Google Drive, and this is how the front page is supposed to look like. This is I've signed into my Gmail, and this is where I can access the Google Drive right here. This is the symbol for that. Once I access it, it's going to come up as looking like something like that. I'm going to make a new folder. Let's say Today is 17th, so I'll just make a folder for today's date. Once it has been created, I can add any file, and in order to do so, I can just upload any file or folder from my computer, or if I want to create a new document, I can use Google Docs and I can just start working on it directly. That's going to be available on my Google account, on my Google Drive, and I can access it from anybody, so anywhere. So let's say if I can start working on a document, I can continue working on it even if I'm traveling, as long as I have access to internet. And you have Google Sheets, which are basically spreadsheets, and they're very similar to Microsoft Excel. Slides are very similar to PowerPoint presentations there. So once you have that, let's say I'll make another new folder. Once I've created this folder, and if I want to share it with anybody, I'll just go on the share option. Over here, I just have to add the email ID of the person I plan on sharing my, allowing access to my folder, and I can even copy the link and send an email to anybody who I want to view the folders that are available on my Google Drive. And once you've done that, you just click done, and you have you've created a folder, you've uploaded your documents, and now you're sharing it with your with your contacts. If you were to compare this to OneDrive, this is how it's supposed to look. This is my OneDrive account. This is my Hotmail account. You can see I'm signed in, and I can I have access to everything through this cursor over here. I'll just click on my OneDrive. This I just create, but I'll create a new folder. Again, we'll have it on today's date. So you can see it just pops up over here. I can upload whatever. It's pretty much similar to what we did with Google Drive. You can see there are, you can add another folder, or you can add a Microsoft document if you want to start working online, or your Excel workbook, PowerPoint presentation, OneNote, or you can even have a survey. If you want to start up a survey for anything, you can just create it online and just save it to this folder. And if you want to upload something from your computer or from any of your saved files, you can upload that like so. We'll just add another folder so we can start sharing. Once we've added that folder, we're going to start sharing by clicking on this option. So I can just add anybody's email ID on anybody's name, or if I have someone has already saved in my account, I can just add their name, and their email addresses are going to pop up. Once that is done, I can add my message. I'm sharing this document. And once that happens, you can allow them to make edits, or you can just leave them to view your documents without making any changes. And with the sharing settings, you can modify it a little more. This is very specific to OneDrive. This part is specific to OneDrive. So adding a date, let's say I want this document to be deleted by tomorrow. Let's say I want to set up a password. I'm going to set up a password, and I'm going to share the password with the person I'm going to share my document with. Once that happens, I can just apply changes, and I will have I'll have a document that is going to have an expiration date, and it's going to be secured by the password, which I'm going to share with my colleague. So this is I think this is. So yeah, this is pretty much everything that there is about organizing and sharing your digital files and drives, and how to keep it easily accessible. These are the references that I used, and thank you very much. Does anyone have any questions?
Again, thank you. Excellent presentation. Thanks for sharing.
Thank you very much, Doctor. If there are no more questions for me, I think we can move on to our next presentation of the day. And the next presenter is going to be, the next topic is on oral cancers, and it's going to be presented by Dr. Walaa.
Hi everyone. Assalamu alaikum. Just let me know if you are hearing me and you can see my screen now.
Yes.
Yes, we can.
Okay, thank you. So thank you so much for giving me this opportunity to talk about the oral cancer. Thank you so much, Dr. Nader, and thank you for our colleague and the white team. This is my agenda today. We're talking about the oral cancer. I will go through all of these topics or all of these headlines. The definition of the cancer is uncontrolled growth of abnormal cell in the body. Cancer develop when the body normal control mechanism stop working. We will go to the oral cancer. Oral cancer include the cancer of the mouth and at the back of the throat. Is also the cancer develop of the tongue, the tissue lining, and the mouth and the gum. There is the type of oral cancer: squamous cell carcinoma, verrucous carcinoma, and there is the minor salivary gland carcinoma, lymphoma, and mucosal melanoma. The squamous cell carcinoma is the most type of oral cancer. More than 90% of the cancer that occur in the oral cavity are the squamous cell carcinoma. Normal, the throat and the mouth are lined with the so-called squamous cell, which are flat and like the fish scale in the microscope. And the least of these cancer is the verrucous carcinoma. This is about 5% of all oral cavity tumor with a slow growing cancer made up of the squamous cell. And this is the type of the oral cancer is rarely spread to the cancer, other to the part of the body, but it may invade nearby tissue. The incidence of the oral cancer overall is 11.5 adult per 100 billion will develop oral cancer. Oral cancer incidence rate are significantly high for the male than the female. The incidence rate for the all age in the male is near 3 times greater than in females. Oral cancer incidence rate are high in the white male than the Hispanic and black male. The incidence of the oral cancer will increase with age. The increase become more rapid after age 50 and particularly for adult age 65 years and older. A risk factor. One of the biggest risk factor of the oral cancer is tobacco use. This is include smoking, cigarette, cigar, and pipes, as well as the chewing tobacco. The risk factor of the oral cancer is most of the human papillomavirus, chronic facial to the sun exposure, previous diagnosis of the oral cancer, family history of the oral or the other type of the cancer, weak immune system, poor nutrition, and genetic syndrome. There is the signs and symptoms of the oral cancer. Also, we have the early and late signs. The early signs and symptoms is present in the red or white patch. There is non-healing ulcer. This is going to be persist for more than 2 weeks. There is without healing. Progressive swelling or enlargement, unusual surface change, sudden tooth mobility without apparent cause, unusual oral bleeding or epistaxis, prolonged hoarseness or the change in the voice. And there is also late signs and symptoms. The dysesthesia or paresthesia, the esthesia of the tongue or lip, airway obstruction, chronic earache, otalgia, trismus dysphagia, cervical lymphadenopathy, persist pain or referred pain, altered in vision, and weight loss. And how we can screen and early detect of the oral cancer. Regularly, the dentist, physician, or the family medicine, he can detect that during regular examination. We can go through history, physical examination, and the biopsy. The clinician should review the social and medical history and should document the risk behavior, tobacco and alcohol usage, a history of the head and neck radiotherapy, family history of the cancer. There is the most important information. Patient over 40 years should be considered at the high risk of the oral cancer. In the physical examination, we can inspect and palpate head and neck, oral and pharyngeal region. Procedure involves digital palpation of the neck node region by manual palpation of the floor of the mouth and the tongue, inspection with palpation and observation of the oral and pharyngeal mouth with an adequate light source. It's going to be much help. This is just a little bit photo through the examination from A and B, all of the oral cavity from the gingiva, lip, and the buccal, and there is the vestibule area, on the palate area, on the tonsil area, on the floor of the tongue, on the lateral border of the tongue. The biopsy is the most important in the screening and detect the oral cancer. So the biopsy is the medical test that involves taking a small sample tissue from the affected area. So always prevention is better. Help prevent the development of the oral cancer by healthy lifestyle, avoid tobacco use, limited alcohol intake, reduce exposure of ultraviolet light. So after that, we will go to the treatment. Treatment for the oral cancer depends on the cancer location and stage. As we know, we have a different stage of the oral cancer. This is not here in my screen. Stage 0, so that is the first stage, or we are calling it the carcinoma in situ. This is the first described abnormal cell in the lining of the oral cavity, and then after that the stage is going to the stage 1. This is more than 2 centimeters and less than 4 centimeters, and after that we will go for the stage 2. It is 2 centimeter and not more than 4 centimeter as well, and the stage 3 is going to be more than 4 centimeters, and it's spread to the lymph node. And the stage 4, this is advanced stage mouth cancer. It may be any size, but it's going to be spread to the near tissue or the lymph node. So all of these, and depends on this stage, we can go to through the treatment. Treatment of the oral cancer depends on the cancer location and stage, as well as overall health and personal preference. You may have just one type of the treatment, or you may undergo a combination of the cancer treatment. The surgery. Surgery to remove the tumor. The surgeon must cast away the tumor and margin of the healthy tissue that surround it. It is ensure all of the cancer cells have been removed. A smaller cancer may be removed through the minor surgery. Large tumor may require more extensive procedure. The surgery to remove the cancer that had spread to the neck. If a cancer cell have spread to the lymph node in your neck, or if there is a high risk that it had happened based on the size or depth of the cancer, a surgeon may recommend it to procedure to remove the lymph node and related tissue in the neck. Surgery to construct the mouth. A surgeon may recommend it to reconstructive the surgery to rebuild mouth to help region the ability to talk and eat. The surgeon may transplant graft of the skin, muscles, or bone from the part of the body to reconstruct the mouth if necessary. And the second line of the treatment is radiation. radiation therapy use the high energy beam such as X-ray and proton to kill the cancer cell. Radiation therapy is often used after surgery, but sometimes it may be used alone in early stage mouse cancer. In other situations, radiation therapy may be combined with the chemotherapy. This combination increases the side effect of radiation therapy, but it's also increase the side effect. And there is the other line of the treatment is the chemotherapy. Chemotherapy is the treatment that uses the chemical to kill the cancer cells. Chemotherapy drug can be given alone, in combination with other chemotherapy drug, or in combination with other cancer treatment. The targeted drug therapy, targeted drug treatment mouse cancer by altering a specific aspect of cancer cell that fuel their growth. Targeted drug can be used alone or combination with the chemotherapy or radiation therapy. And there is also immunotherapy. Treatment are generally reserved for people with advanced oral cancer that's not a response to the standard treatment. And this is my reference. And that's all about the oral cancer. Just I want to minimize the information. I know this is the whole and this is the big topic. That's all I have to present it today and share it with you. If you have any question, just go ahead.
Thank you so much, Dr. Walaa, for great presentation. Excellent work. Thank you. Very helpful.
You're most welcome. Most welcome. Thank you.
Thank you very much, Dr. Walaa. That was a great presentation. Are there any questions from anybody? Okay, thank you very much. I think that's it for the presentations for today. Now I'll just leave the floor with to you, Dr. Nader, so we can discuss any upcoming projects, or if anybody wants to discuss any project they're working on, just to update the group and the team.
Yes, please go ahead if you have any updates. Thank you.
Yes, that's me again, Dr. Walaa. I have update. We have our group of dentists. We are almost done about our application in our dental group. Just small touches and images we'll add it during this week, and we will provide the access for you, and we need your feedback about that, if you don't mind.
Excellent. Good. Let me know when that's ready. Thank you.
Okay, by the end of this week, inshallah.
Sure. Anybody else?
Hi, Dr. Nader. Hi, everyone. I'm glad to share with you that our new version of INR monitoring app was released to Google Play Store. And I would like to thank Dr. Nader for the great opportunity. It's been a wonderful journey with this application. And I would like to thank Dr. Ala and Dr. Nafisa for being great co-leaders, and also thank all team members for their hard work. So our next steps include that we want to spread our application. We want, yes, it's true that the app is in Google Play Store now, but we have hard work, we want to spread the application among physicians and in the US or other countries. Thank you so much, Dr. Nader.
Thank you so much for the update and excellent work. Thanks to you and to your team, and great work. So yeah, so we can think about how we can approach our physicians and show them this useful tool so they can share it with other patients who are on anticoagulation. And it's gonna be in in the US or in the Gulf area or Sudan, Egypt, and anywhere. So great, thanks. Anybody else? Any other ideas or any questions? I know some of you attended the review board course online. Any updates or comments? Go ahead, Dr. Hadeer.
I was just wondering about the NAP CRG. I was planning to, me and my team, I mean, we were planning to submit something. So I wasn't sure about the research questions that we are looking into. It's like the demented patients and the challenges that they may face in primary care, I mean, in regular visits. So I wasn't sure if it's applicable for this to submit it or it's not. There are many papers on this aspect, so I was wondering if we can work like on a systematic review, but I'm not sure if it will be accepted or not in this type of.
So if you look at their previous accepted posters or abstract, you can get an idea as far as like what they accept and they're interested in.
Okay. So it should be like something similar to the things which were accepted before, or it can be.
Hello.
Okay, so I'll have a look again on the accepted abstracts, and maybe we can do something similar, but maybe on a different topic. If the topic we're, I mean, thinking about is not very applicable, we might change it to another thing.
If you guide me on just what exactly the question, so patients with dementia coming to the clinic, what you are looking for, what.
So the question is how to deal with the challenges that these patients might have while visiting the, I mean, how to go into the screenings on their times because they are having cognitive impairments and usually a caregiver is taking care of these things. So I was just thinking, does this affect, you know, the regular screenings like colonoscopy, these kind of screening? Do they usually, you know, don't go to their screenings because they don't keep track of it because of their, you know, other issues they're facing?
Excellent. So after you have the question in mind, that the next step is how you are going to collect the information. As you mentioned, there are ways like if you think it's done before in many studies, then you will do the review, systematic review, and can answer the question that way. Or if you are thinking of collecting data, then you think about how you can approach clinics where they see patients with dementia. Then you can do a survey of questions to these providers. So after you make your question, then the next step is the method. How are you going to address your question?
Yeah. So I guess because the due date for the submission is in July, so I don't think we will be able to do like collect data from clinics. And so I was thinking about something like a review because there are actually lots of data there about this kind of stuff. So.
All right, that might be a good option. Then just create your team and start working on that, and we can submit it as a project in progress.
Okay, great. Thank you so much.
Thank you. Yeah. Thank you. Anyone else? Any other ideas or questions?
Yes, Dr. Nader. I just I want to know. I'm starting like also. Till now, I didn't start like collecting data about one topic I'm thinking about, and I updated the red team leader, which I belong to. So, but because the timing, as you know, is narrow for this season, can we just like go for a narrative review just to do it before the deadline, which is September?
So the NAPGREC is kind of a two option conference where they can accept a completed project to be presented, or they can accept an in-progress project. So if you have the idea, if you have the method, if you started collecting, or let's say you get the approval from the IRB and then approach whatever, let's say hospital to them to get the data, then it will be considered a project in progress. You can submit your abstract in the form of idea, or you start in a project that's in progress and they can accept that. So you can present that and you can say, we are in this phase of the project. Let's say we are in the data collection phase, or we are in the data analysis phase, or we're still working on taking the conclusion, for example, or something. So your project is still in progress. They can accept that, and you can present just the part where you finished and your plan for the next year to present it again, but in a complete format and when you complete the project, if that makes sense.
Yeah, okay, that's clear, but I think I didn't set my point very clear. So I'm talking about being able to publish this topic before this season of residency application.
The residency, when you submit it, you can put it in your application as a submitted abstract. By the time, let's say September, mid-September, if you learn that the poster has been accepted, then you will put it as accepted poster. If let's say by November we have time to present it, then you change that into a presented poster, if that makes sense. So you can change until the time when you submit your application as according to what stage of the process of your, in this case, abstract, let's say. And the same with manuscript. So let's say you want to write an article. So you are in the process of writing the manuscript. When you submit it, then in your CV or application, you will say, this is the submitted manuscript. So you already submitted, but you are waiting if it's going to be accepted or rejected. No one knows. So you wait. By the time you finish your application in the and you want to submit, wait and see if you get the result back from the journal. If they say accepted with some reviews, so you will do the review. So you will say this being accepted. It's not published yet. And by the time it's published, then you go in your say published work, you can submit that as a published project.
Okay, thank you so much, Dr.
You're welcome. Saba, go ahead.
So doctor, I was thinking of work. I was thinking of a topic to for an abstract for if to submit for a NAP CRG conference, but I wanted to first. I wasn't sure if it's if the topic is good enough, or if I should even if it's something I should proceed forward. with, but I was thinking of doing a narrative review for an abstract on frailty screening and management in primary care, and basically just trying to get a good comparison on different screening tools that are used in primary care, and just trying to, so that I can have some form of data as to which may be slightly superior to others. So I'm thinking on those lines. Do you think this is a topic that I should continue forward with, or I should think of some other topic?
No, I think it's a good idea, and I think the fellows in the past, they did similar ideas. One of them is review, systematic review about tools are used for dementia assessment and so forth. And the other group work in elder abuse in clinics, so they submitted some maybe survey or some. So they did approach some clinics and get some information about how they do that. So you can do it either or if you want to collect information. But for you, if you have a good idea and you have the method, with these two, you can put your product down and then see when you start how far you go. By July 15 or the deadline for the submission, you can submit that as a project in progress or an abstract in progress. So you have the idea, you have the method, maybe you started, if you are starting, let's say, contacting the clinics. So you are finished with the questionnaire and now you identify the clinics. So it's a matter of getting data from this. So you would say we are in this phase of the study or of the project. You submit that and hopefully it will be accepted. So you have the idea and the method in written format. So the step for the next phase will be the data collection. So if you are in that phase, you can submit your work.
Okay, thank you, Doctor. But I might not have time for collecting data. That way, I was thinking about doing a narrative review by and using studies that have already been published.
It's gonna be the same where it's gonna be you are doing a review, right? So you have the idea, you have the method, it's gonna be a review, and you know how you do the review. You're gonna put all this in one paper, and then you'll say we are in the process of, let's say you started getting some articles, and now you are reviewing this article. So you are in your submitted format, you will say we are in this phase. So people will know that you started and you reach this point, but you didn't complete, you didn't finish all the analysis and so forth. So they will accept it that you are working on this project, and hopefully by next year you'll finish all the, and then if you submit it next year to the conference, it will be an accepted full project.
Okay. Thank you very much, Doctor, for the feedback, and I'll definitely look into it. Thank you.
Yeah, if you want to start a team and then divide your task, and hopefully you can get it. Hopefully you can get it done. If not, you just submit it as work in progress.
I can share it on the WhatsApp groups, and hopefully, I'm hoping that somebody would be interested, so I can put together a team and we can start working on it.
Sounds good. Let me know if I can be of help. Yeah. Excellent. Anything else? Any other questions, ideas, comments, updates? If not, then we will work on seeing you next week, hopefully. And I wish you all the best. Thank you so much again, Dr. Saba, and your team. Thank you all the presenters. Thank you all the fellows who attended this meeting, and the one who will review this recording later. I wish you all the best. Thank you. Have a wonderful day or night or evening. Assalamu alaikum. Yeah.
Thank you very much, Doctor.
Thank you
Thanks.
so much. Alaikum assalam.
Have a good day. Enjoy the rest of your week.
Thank you.
Thank you, Dr. Nader. Thank you so
Thank
much.
you very much. Bye bye.
Thank you, Dr. Nader.
Thank you.